1918, Dr. George Charles is from Australia University of Sydney.
Mr. Chairman, ladies and gentlemen, thank you very much for the opportunity of being able to speak at the meeting. I thought that since this meeting is being held here in Greece, this would be an interesting little case to talk about. Now let me see that I can advance this. Yes, so what I'm going to be talking about here is one of the thrombotic microangiopathies. It's really the history of typical hemolytic uremic syndrome. Some call it D+, diarrhea plus, or STEC-HUS. And what I shall not be addressing is atypical hemolytic uremic syndrome or thrombotic thrombocytopenic purpura. Now, probably most people in the audience will know what we're talking about when we're talking about hemolytic uremic syndrome, but there may be occasional people in the audience who don't. So just to put everybody in perspective, this is a condition which nowadays we look upon as being commonest in children up to the age of about 5 years. It often occurs in epidemics in summer months, and it usually starts with diarrhea. It's often quite bloody. People have abdominal cramps, sometimes fever, lethargy, anemia, sometimes bleeding elsewhere. They become oliguric, anuric, acute renal impairment. 50% of them probably require dialysis to survive, but in this day and age with available facilities, only about 2% die during the acute phase, although 25% of them get some neurological complications. These can come and hopefully pass away. Nevertheless, about 25% of them are left with a degree of chronic renal impairment. Now, when one talks about hemolytic uremic syndrome, if one looks at most of the textbooks, one sees comments such as this one. This is from Brenner and Rector's book, the current edition. The term hemolytic uremic syndrome was introduced in 1955 by Gasser and co-workers in the description of an acute fatal syndrome in children characterized by hemolytic anemia, thrombocytopenia, and severe renal failure. And Gasser and co-workers, quite rightly, are given huge credit for this condition. But there's always been this vague sort of awareness that there were one or two previous cases, and I thought it'd be interesting to explore them. So, to put it then in perspective, in 1898, renal cortical necrosis was first described. And that was described by a very famous British physician, J. Rose Bradford. And it was in a woman who had just given birth to a stillborn fetus, and she became anuric. She died seven days later. And at autopsy, she had shrunken renal cortices, tubular necrosis, narrowed renal arteries and arterioles with very thickened intima and media, and thromboses. There were only minor glomerular changes, there were only minor interstitial changes. Now, this is looked upon as a very rare condition, and there are really only 10 subsequent cases that were reported from 1898 through to 1920, and all of them had occurred in pregnant women. Then, in 1918, a case occurred that was not in pregnant women. And then, to just put this into perspective for you, this was a case that occurred in Thessaloniki, here in Greece, not far from where we are today. So, what was happening on the 10th of October 1918 when this patient was admitted to hospital? Well, Europe was at war. The First World War was coming to an end. On the Western Front, Germany had just lost that day, I think, lost the Battle of Cambrai. On the Eastern Front, civil wars were raging in the countries that were escaping from Russian control. On the Macedonian Front, which often doesn't get nearly as much discussion as the other fronts, but Germany's ally Bulgaria had surrendered on the 13th of September here at Thessaloniki after being defeated by French and Greek forces. And of course, on the Turkish front, the Ottoman government was collapsing, and it resigned just 3 days later. So things were happening in the big world. And what about here in Greece? Well, Greece was not a particularly happy country at that time. And please, if the Greek gentlemen and ladies in the audience feel that I make mistakes with your history, please forgive me. I'll just do my best to get it correct. But I think between 1900 and 1914 there have been several Balkan wars and territorial disputes. King Constantine had been reigning from Athens, but have to bear in mind, King Constantine was married to a lady who was the brother of the Kaiser in Germany. At least she was the sister of the Kaiser in Germany. Constantine himself was a military hero against Turkey, and he recreated the Olympic Games. He claimed to be neutral in the First World War, but he was considered by many people to be pro-German. On the other hand, he had a prime minister, Venizelos, who led a rebel government, and that had moved from Athens up to Thessaloniki. And Venizelos was an Anglophile, and he managed to garrison, although Greece was neutral, managed to garrison Thessaloniki with British and French troops. This was on the pretext that they were defending Serbia and perhaps Greece from Bulgaria, which was an ally of Germany. And so in July 1917, Venizelos had actually declared war on Germany. Constantine fled into exile. His son was made a puppet king in Athens and kept imprisoned in his palace there. What I believe Greek historians describe as the national schism occurred of the royalists versus the Venizelists. So Greece was a very tense country, threatened both internally and externally, and not surprisingly, public health standards weren't all that good because of all this political turmoil that was going on. So what was the British Army doing in this area? Well, from 1915 to 1921, it had quite a big force, almost 250,000 officers and men. And there was an equally large French force. The British force had been recruited from Britain and throughout the British Empire. It had amongst its troops a labour corps whose task was to build ports and railways. It had medical and nursing staff, had 8 hospitals. Infectious diseases were absolutely rife. There were 160,000 cases of malaria, much influenza, diarrhea in many, many soldiers, 4,780 deaths. And I was able to obtain this photograph, actually, of one of the British general hospitals. This actually comes from a photograph album in a nursing museum in Sydney in Australia, because quite a number of Australian nurses were involved, and they sent back photographs of where they had been working. So you can see the tent-type hospital. It was not the sort of facilities we're used to these days. And there were the medical and nursing staff. So, Private W.C. Was written up as dying from cortical necrosis. He's aged 37, and this is in the report. I'll show you the photograph of it in a moment. He'd been in the army for 2.5 years. He was a soldier in the Labour Corps. He was admitted to hospital. Well, he had suffered an episode of influenza, but then he was admitted to hospital with headache and vomiting on the 10th of October 1918, and went through a medical history described day by day in the published article, in which diarrhea was a very, very prominent, bloody diarrhea, prominent component. He got more and more sick. He did have a few malaria parasites on a blood film. The only treatment that was available for him was intravenous saline and sodium bicarbonate and some quinine for the malaria. But he became anuric, delirious, unconscious, and died on the 20th of October. And he had an autopsy performed 11 hours later. And what did the autopsy show? Well, in his kidneys there was widespread necrosis, except in the subcapsular areas, some areas of hemorrhage. Microscopically, the arterioles were filled with amorphous material and thrombi. Glomeruli contained fibrinous thrombi. Tubules were necrotic. The interstitium was unremarkable. No malaria parasites. And the conclusion, symmetrical cortical necrosis of the kidneys. There was also necrosis in the liver. So this was extraordinary because it was the first case that, to the awareness of the people involved with him, that was occurring of acute cortical necrosis that was not in a woman associated with pregnancy. And so Dr. Joseph Bamforth wrote an article that was not published until 1923, a case of symmetrical cortical necrosis of the kidneys occurring in an adult man. Now, who was Bamforth? He was, after the First World War, he went on to become a pathologist, assistant bacteriologist and general pathologist at St Thomas's Hospital in London. Dr. Cameron Morris, who went on to become a paediatrician, provided the clinical notes, and the autopsy was done by Bamforth, but the microscopy was done by Professor Dudgeon from Liverpool University, but also who then became the director of pathology at St Thomas's Hospital in London. And that is the paper describing this. So I thought it would be interesting to try and identify who was this private WC. And the thought came to me, well, he died on war service. All British and British Commonwealth soldiers who die on war service get buried locally, and their graves are thereafter looked after by the Commonwealth War Graves Commission. So I contacted the Commonwealth War Graves Commission, knowing what his initials were, and they were able to tell me that there was no private WC who died on that day, but in Thessaloniki there was a private CW, Charles Watson, who was in the Labour Corps and who fitted the description, who died on that day. And so able to identify who was this first person who probably suffered from described as suffering from hemolytic uremic syndrome. He'd been born in Essex, now in Greater London. He was a bricklayer in civil life. He married a widow, had 3 children. I followed by going through the British census records and then births, deaths and marriages records, all of which are in the public domain. I was able to identify him in quite a lot more detail. And you can find that in 1916 he enlisted in a particular battalion and ended up here in Thessaloniki. So that was the first case. And then thinking, well, I wonder if there have been other cases. So I dredged the literature and found, yes, there was another case. Oh, this was interesting to me as an Australian. This was described from Sydney in 1952, whereas Gasser and Company's report was in 1955. Hensley, William Hensley, ultimately a biochemist in Sydney, described an 8-year-old boy, previously healthy, diarrhea, anorexia, oliguria, convulsion and dropsy. Convulsion became drowsy, and he had pallor, occasional petechiae, anemia, thrombocytopenia, raised blood urea level, was transfused, but nevertheless died. And this was the paper that was published about that case, hemolytic anemia in what he described as acute glomerulonephritis. And on autopsy, the kidneys were enlarged and congested with pinpoint hemorrhages. Afferent arterioles were particularly involved. The glomeruli had necrotizing inflammatory process. Not sure exactly what he is meaning by that. Tubules, severe degenerative changes. In the bone marrow, there was excessive erythropoietic tissue, implying that there was, and also megakaryocytes were present, implying that there was red cell and platelet breakdown. Then going on, I was able to find another 2 cases, well, at least 1, maybe 2, described by Sheehan and Moore from Glasgow in 1952. They don't give the dates when these cases occurred, and they give very, very skimpy description of them. Nevertheless, it seems reasonable to attribute them to hemolytic uremic syndrome, at least in one of them. So that led up to Conrad GASSER'S and his colleagues' brilliant paper that was published in the Swiss Medical Journal in 1955. And I have not actually been able to find an English translation of this paper, which makes it difficult for people like myself who can't speak German. Nevertheless, when I worked my way through it, what it seemed to describe as 5 children aged 2 months to 7 years, who were ill between 1946 and 53, so they're actually occurring before the previous couple that I mentioned, and they had hemolytic anemia, fragmented red cells, thrombocytopenia, cerebral involvement, acute renal failure, just the sorts of things that we now look upon as occurring in acute hemolytic uremic syndrome. And so many subsequent descriptions thereafter appeared from many countries describing the anatomical pathology and so on. There's a proposal as a bowel infection as its cause, because in 1966, in an isolated area in North Wales in the United Kingdom, Muriel McLean described 7 out of 10 cases that occurred as an epidemic in an isolated area, and so proposed that some external toxin or infectious agent acting on the bowel probably causes it. Then Renée Habib and her group in Paris did an electron microscopic study of 6 French patients, and they were able to show gross hypertrophy of the glomerular endothelial cells, ramification of the peripheral cytoplasm, and a sublaminar deposit of irregular density with many platelets deposited. And this is putting together then the picture as we understand it. That led to people at the Centers for Disease Control in Atlanta, Georgia, identifying a strain of bacteria that grew from the stools of 9 patients who were involved in outbreaks of gastroenteritis with hemorrhagic colitis, all of whom became ill after eating hamburgers produced at a particular restaurant chain. And then that led on to the discovery of the particular toxin, which is a virotoxin. Viro cells are from African green monkeys, which the toxin from this bacteria would act upon. And they led through step by step by step to a realization that this was like the toxins released by Shigella infections, so called a Shiga toxin. Then in Canada, in Toronto, a demonstration that the endothelial cells are the particular item of damage by this particular toxin, and a focus, a realization that mesangial cells, as well as others, also can be damaged, but it's particularly endothelial cells because of certain receptors on their surfaces upon which the toxin acts, and that the toxin gets carried to those cells being carried on white blood cells. And then this finally led to a realization, hey, where are all these bacteria coming from? And there have been international surveys done to find out what animals are particularly infected. They're mainly cattle, mainly young cattle. And so it raises the question, how did this disease, which is such a distinctive disease, not get described by anybody before 1955, or maybe, if you like, before 1918, 22? Perhaps there was a mutation that occurred within the bacteria at that time, maybe in the awful conditions of the First World War, and people eating undercooked food in military camps, which actually occurred then and triggered the onset of the disease.
Enlightening the issue of hemolytic uremic syndrome. Hopefully next edition of RENAL will have some collection. Thank you. And any question? Oh yes, please. Go ahead, go. Okay.
Thank you very much for your excellent presentation of this history of hemolytic uremic syndrome, beginning with the case in the First World War. I have only a comment or question. The use of the name against the surname for making catalogs in military service is in Greece every time, for a long time, the case. That's why also the state and in the schools we use the surname to make the catalogs. It is, I think, coming from military service. Is that so in United Kingdom as well? Or in Australia?
Yes, and I'm afraid that I'm not a good enough military historian to be able to answer that question. I apologise, but it's an interesting question. Yes.
It's an interesting question. I don't know the answer.
Yeah, quite likely, I suspect. Quite likely.
Yes.
Thank you so much for your presentation, because I think this is a comment. This is very important. I remember that 5 years ago in Europe there was an epidemic situation in Germany, I think. And the history, you are very right, because you amplify the concept of history of nephrology. They searched for many, in Germany, searched in the past during this epidemic for many agents, but the history was clear. They saw the history, and your presentation is very appropriate. The solution was in the hand, was clearly so. If we present also simple evidence, the only one simple evidence is not idiotic, but is very important for the future. And you are very right. I think too much, because we must diffuse this concept. Thank you.
Thank you very much for that comment.
Thank you very much for the next presentation.